Hello everyone, welcome to this module on bronchial asthma. Bronchial asthma. Bronchial asthma is again a very important topic, both from your clinical perspective and for your exams. So let's start with what is this bronchial asthma. Bronchial asthma is an obstructive airway disease, which is characterized by a reversible airway hyperresponsiveness. So this is a obstructive lung disease. This is a obstructive lung disease which is characterized by reversible airway hyperresponsiveness. So you can put it as an abbreviation AHR, airway hyperresponsiveness. So that is what is your bronchial asthma. Now, how is bronchial asthma different from an obstructive lung disease like a COPD, a chronic obstructive pulmonary disease? So let's just try to compare both. So see this is just a figure that is showing the various obstructive lung diseases. You have emphysema, chronic bronchitis and asthma. The major differentiating point between asthma and maybe an emphysema or a chronic bronchitis, that is your COPD, is that the asthma, the airway obstruction is reversible. It's a reversible obstruction that you get in case of asthma, and the airway disease per se in the asthma is affecting mainly the bronchi. So it is predominantly a bronchial hyperresponsiveness, whereas in case of your emphysema, the small airways can be involved, like your alveoli. There is an alveolar wall destruction, there is an alveolar inflation. So that is what happens. So here you have a bronchial hyperresponsiveness. So that is your airway hyperresponsiveness in bronchial asthma. Alright, so you understood what is this bronchial asthma in a nutshell. Now just moving on to further details of bronchial asthma. See, for this airway hyperresponsiveness to happen, there should be some cause, correct? There should be some cause for this, and there are various triggers, there are various risk factors for these asthma. And when you deal with the risk factors for development of a bronchial asthma, you have certain endogenous factors. You have certain endogenous factors contributing to asthma. You have certain exogenous factors contributing to asthma. And then in such an individual who has a predisposition to develop asthma, there might be certain triggers which will give you that push to develop the asthma. So there may be certain triggers. Now we are going to see what are the endogenous factors, what are the exogenous factors, and what are the likely triggers of a asthmatic episode. So this is a table in Harrison describing the various endogenous factors as well as the exogenous or the environmental factors. Plus you have the various triggers for the asthma. The endogenous factors include a genetic predisposition. We do not have any definite gene that is solely responsible for development of asthma, though there are postulated genes, but there is definitely a genetic predisposition. And those with atopic tendencies are at increased risk for developing asthma, and some individuals will be having an endogenous airway hyperresponsiveness due to some unknown factors. For them also there is an increased likelihood of developing asthma. Gender, ethnicity, obesity and certain viral infections, these are also postulated endogenous factors for the development of asthma. Now coming to environmental factors, I am sure you know most of the environmental factors, like it may be some dust, it may be pollen. So there can be various allergies that can trigger or allergens that can trigger an asthma. So you can have indoor allergens, outdoor allergens, occupational sensitizers. You might have maybe a particular individual who is working in a cloth factory where sometimes the dust from the cloth production unit might be the trigger for that particular individual. Passive smoking again is a very important risk factor. Respiratory infections, air pollution. For some individuals, there may be dietary triggers as well. For some, it may be egg. It may be, maybe prawns for someone else, shellfish. So all these may again act as triggers for, can act as risk factors for development of asthma. Then dampness and mold exposure, and for some individuals even drug allergies can also be there contributing to asthmatic episode. Okay, so there are various factors causing this. And then what are the triggers? By trigger I mean that in somebody who has gotten asthma, sometimes exposure to a particular trigger can flare up that particular episode. So which may be allergens, maybe a upper respiratory tract infection. For example, if someone is having a bronchial asthma, when he develops a respiratory tract infection, that respiratory tract infection may serve as a trigger for the development of asthmatic episode in this particular individual. Sometimes exercise and hyperventilation. Okay, there is an entity by name exercise-induced asthma as well. Exercise-induced asthma as well. I do not mean that anybody and everybody who does exercise is likely to develop bronchial asthma. No. In certain individuals who are having a particular genetic predisposition, sometimes when they do exercise, there is an increased likelihood of developing a bronchial asthma. So there are certain theories with respect to this exercise-induced asthma. You have got a theory of thermal theory, okay, that is on the elevation of body temperature that is triggering a asthmatic episode. And you also have an osmotic theory, which means when you do exercise, there will be a loss of this water and electrolytes, and this indirectly can trigger the asthmatic episodes. So there is an entity, know that there is an entity by name exercise-induced asthma. Cold air can trigger asthmatic episodes in some individuals. Sulfur dioxide and irritant gases, drugs like beta blockers and aspirin, stress, irritants, all these can act as triggers for asthma. Okay. So these are the factors contributing to the development of asthma. The gray area is the genetic predisposition. We are not yet able to pinpoint a particular gene that is responsible or what makes a particular individual likely to develop asthma. But we are quite sure of one thing, there is a definite genetic predisposition to asthma. Okay, alright. Now we will just see, after having understood the various factors contributing to it, short overview on the actual etiopathogenesis of asthma. The risk factors, etiologies probably we have seen, but what exactly happens in your airway, that is what we are going to see. Okay, so this is a picture again, I've taken this from Robbins. See, whenever somebody develops an asthmatic episode, it actually proceeds through certain stages. There is an initial triggering stage, okay, where the asthmatic episode is triggered, and subsequently you have an immediate phase and then a late phase. That is how asthmatic or maybe an asthma episode would progress. Now let's see what happens here. Now in asthma, again you know that there has to be some immune response for this airway hyperresponsiveness, because there is some sort of an inflammation also happening. So what happens is that when there is an antigen, okay, I told you a whole list of antigens that can contribute. Suppose if it is pollen, okay, and if you have that extraneous antigen or allergen, it is first dealt by the dendritic cells, and subsequently there is an antigen presentation to the T cells. Now among the T cells in bronchial asthma pathogenesis, it is the Th2 subtype that is most important. That is your T helper 2 subtype is most important in the pathogenesis of asthma, not the Th1. Now when the Th2 cells are activated, what results is that it results in the release of interleukin 5 as well as eotaxin also. Okay, there is a release of eotaxin also. This interleukin 5 is a very potent eosinophil activating cytokine. This is a very potent eosinophil activating cytokine. Okay, eosinophil activating cytokine. So this will thus cause the recruitment of eosinophils. That is, both the IL-5 and the eotaxin together will cause eosinophil recruitment. Now mind you, this eosinophil is the most important cell type that is involved in the pathogenesis of asthma. Very important. So this eosinophil is so important, and this eosinophil activation will subsequently cause a release of certain granules as well as certain mediators that would further incite the subsequent changes that happens in an asthmatic patient. Okay, so the release of mediators from eosinophils is very important. Now, along with the activation and recruitment of eosinophils, you also have activation of your B cells, and there is production of IgE antibody, and this IgE antibody subsequently will interact with the mast cells as well, and subsequently what happens is that the mast cell activation and degranulation also take place. So in the early phase, in the triggering phase of asthma, the end result is the activation of eosinophils as well as the mast cells. Okay, all right, then let's see what happens next. Okay, now when the mast cell, you can see here the mast cell is activated, subsequently that what can happen is that there can be certain changes happening in your smooth muscles, because ultimately in an asthmatic patient you have got to have a bronchospasm has to be there. So there is changes that is involving the smooth muscle, and there is increased vascular permeability as well as edema also happening. Okay, and also what you see is that there is a release, that you can see the eosinophil here. It will cause release of the major basic protein and eosinophilic cationic protein, because I already told you there are certain mediators which are very important in the asthma pathogenesis. So when these mediators are released, it brings more and more cells to the picture. You have the basophils, neutrophils, more and more Th2 cells, and subsequently it actually incites the inflammatory response. Okay, so that is what results in the immediate phase and the late phase of asthma. So an antigen triggers it, subsequent Th2 cell activation, subsequent mast cell activation and degranulation, eosinophil activation and degranulation, subsequent changes happening in the airway, smooth muscles, the inflammatory cells, the change in vascular permeability. All this is actually leading to asthma, and you can also see the increased production of mucus as well. Okay, increased production of mucus as well, leading to bronchial asthma. Okay, these are the changes that happen in a bronchial asthma patient, the pathology that happens. Now again, just to compare an individual's normal airway versus an airway in asthma. Okay, let's have a comparison. So here you see, it is very obvious that you have good amount of mucus production. Yes. And what happens is that you can see that the basement membrane, just compare with the basement membrane of a normal airway, you can see it's very much thick. Correct, no? There is a thickening of the basement membrane. Okay. And you can see the inflammatory cells, the macrophages you can see. Yes. And can you also see the increased amounts of smooth muscle in the airway compared to a normal airway? Yes, and you can see the proliferation of glands also, very much, okay, compared to the normal. You see so much of glands are there, and yes, all these inflammatory cells, mast cells, eosinophils, neutrophils, all these inflammatory cells also contribute to the pathogenesis of bronchial asthma. Okay, so I think we have got a good idea on what is the pathology that happens in case of a bronchial asthma. So just to summarize, this is just another section of the airway, another figure I have taken from Harrison. So you can see what are the changes. You can have a mucus plug which is trapped with the various inflammatory cells. You will get goblet cell metaplasia. Inflammatory cell infiltrate. We have already seen the Th2 cells, eosinophils, neutrophils, basophils. Predominantly it's the eosinophils and Th2 cells, and the basement membrane is very much thick, very important point. And thickened airway smooth muscle and normal parenchymal attachments. The airway smooth muscle also is actually like compared to the normal individual, the layer is very much thick here again. Okay, so these are the pathological changes that happens. Now just two additional questions which I am sure you have learned in your pathology. So what is this? Any idea? This is obtained from a patient. So of around 70 years, diagnosed case of bronchial asthma, now coming with an exacerbation of an asthma, and the bronchoalveolar lavage fluid was taken. It was centrifuged, and this is one finding that was obtained from the centrifuge sample. Any idea of these spiral structures what you are seeing here? Any idea? So that is going to be your Kirschmann spirals. Okay, Kirschmann spirals. Now what are these Kirschmann spirals? They are nothing but the basophilic mucus plugs. Basophilic mucus plugs in an asthmatic patient. You call them Kirschmann spirals. Clear? Okay. Next, another pathology finding. In case of bronchial asthma patients, you may also get. Can you tell me what are these? Can you recollect your pathology lessons? These are degradation products of your eosinophils. And what do you call them? They are called your Charcot-Leyden crystals. Charcot-Leyden crystals. Okay. So they are the degradation products of what? Eosinophils. Okay. Because you know that eosinophils are the central part in the pathogenesis of bronchial asthma. Okay. All right. Now, just to sum up again, you have lots of inflammatory cells in bronchial asthma. So you see mast cells, eosinophils, Th2, basophils, neutrophils. Even platelets are also said to have a minor role. Then you can have structural cells, because we just saw the smooth muscle thickening. So epithelial cells, smooth muscles, endothelial cells, fibroblasts, nerves, they are all involved. You have lots of chemical mediators. Okay, lots of chemical mediators, because this is an inflammatory process. Naturally, there has got to be chemical mediators. So you have got histamine, leukotrienes, prostanoids, platelet activating factor, the kinins, the bradykinins, adenosine, endothelin, nitric oxide, cytokines, chemokines, growth factors. So you get an idea now on how complex is the pathogenesis of asthma. Though we have put it in a simple way, it is not just one or two chemical mediators that are mediating this airway inflammation. You have got a whole list of chemical mediators taking part in this pathogenesis. And ultimately, what is the end result? You know, when these inflammatory processes happen in the airway, what is the end result? The end result is that you may get bronchospasm. We have already seen there is an increase in the vascular permeability, so there is a plasma exudation. There is increased secretion of mucus, and AHR, that is, there is airway hyperresponsiveness, and you get structural changes in your airway as well. Okay, so this is what results in the obstructive pathology of bronchial asthma. So again, just summarizing a chart in Harrison, just a summary of what we have said. The various allergens, endogenous and exogenous factors resulting in an inflammation, which is a chronic eosinophilic bronchitis, because I told you eosinophils are the predominant cells involved. I also told you it is predominantly affecting the bronchi, resulting in an airway hyperresponsiveness. And whenever there is a trigger by some allergen, exercise, cold air, a decrease in saturation of oxygen, or some particulate matter, all these can trigger the airways. And naturally, what will be the symptoms? The patient will be having cough, the patient will be having a chest tightness, a wheeze. So all these may be some mucus production, All these can be manifestations of bronchial asthma. Okay, so all these are actually manifestations of airway hyperresponsiveness. You can put it that way also. Rather than saying these are the symptoms of bronchial asthma, you can say these are the symptoms of the airway hyperresponsiveness. Okay, but yes, cough can occur in other conditions. You can have chest tightness in other conditions. But when there is a reversible airway hyperresponsiveness and an individual is having episodic symptoms, you are likely to be dealing with a case of bronchial asthma, especially if you are also able to demonstrate a particular trigger leading to this particular episode. Okay, very clear. Now I want you to, so after having understood, I'm sure now by now you are very thorough with the basic etiopathogenesis of bronchial asthma. Now you're supposed to know this also, because sometimes when a question comes for your exam, they might actually bring in a few pathology points as well. They might just bring in the options Kurtzman spirals, Charcot-Leyden crystals, or maybe the smooth muscle changes happening. So they might try to bring in some pathologic changes also. So always, you should learn topics in an integrated way, because that is how the exams are heading. You cannot just restrict your studies to say medicine alone. See, when you study medicine, you have got to know physiology, you have got to know your pathology, you have got to know your pharmacology as well, because you're going to treat the patient. So it should always be an integrated learning for you. Okay. All right. Now I'm going to introduce two terms to you. That is, there is something known as an extrinsic asthma versus something that is known as a intrinsic asthma. So we are going to see what are these two terms. See, this extrinsic asthma is also referred to as this is actually an immunologically mediated one. Okay, this is immunologically mediated one. Whereas intrinsic asthma, to be honest, we are not exactly very sure on the pathogenesis. So there are certain postulates on the pathogenesis of intrinsic asthma. So, but it does not have a definite immunologic basis like your intrinsic asthma. So let's see what is this intrinsic and extrinsic asthma. The extrinsic asthma is the childhood onset asthma, where you have a history of allergy. You might have a history of an allergen that is triggering the episode. Maybe the individual has got some atopic tendency. There may be a family history of asthma, because I've already told you asthma has a genetic predisposition. So these are the main features of your extrinsic asthma. In contrast to your extrinsic asthma, in which the onset is a childhood onset, intrinsic asthma is predominantly a middle age or late onset asthma. And here you will not have, I told you, you do not have a definite immunologic basis. So there is usually no history of an allergy or a precipitating allergen. You will not see any background atopic tendency. Family history will be absent. Now when you investigate also, when you do the skin prick test, you have a skin prick test for your asthma, where you are maybe with a lancet, you are just pricking. You will have the allergen, a drop of allergen that is put, and then you are pricking to the skin without causing bleeding, and you are looking for the reaction. So this skin prick test is usually positive in case of a extrinsic asthma, but it is negative in case of an intrinsic asthma. And very importantly, the serum level of immunoglobulin E. We have learned in the pathogenesis of asthma that the IgE levels are elevated in the asthma. But here the IgE levels are in the extrinsic asthma is elevated, but intrinsic asthma is usually normal. Okay, so this is just a comparison between your extrinsic asthma and intrinsic asthma, because sometimes they may ask a question, which of the following is not a feature of intrinsic asthma? Okay, they might ask a question like that. So the intrinsic asthma, again, there may be certain triggers for this intrinsic asthma. Sometimes you might have aspirin as a trigger for intrinsic asthma. You might have heard of something that is known as the Samter's triad, which stands for, you have your aspirin intolerance, asthma, and nasal polyps. Okay, so you've got to keep this in mind. This is the Samter's triad. Okay, so yeah, okay, so this is about extrinsic and intrinsic asthma. Okay, now having understood the asthma etiopathogenesis, the extrinsic versus intrinsic asthma, now we are moving on to the diagnosis of asthma and the management of asthma. First of all, let's see the diagnosis of asthma. Okay, you've got to diagnose asthma. So something which we already know now is that asthma, there is a reversible airway hyperresponsiveness. Correct? Reversible airway hyperresponsiveness. So let's see what is the criteria for making the diagnosis of asthma. So from now on in this module, I will be showing you some direct screenshots that have been taken from the guidelines itself. Because guidelines, you have to strictly adhere to that. Okay? Because asthma, certain guidelines, management is like, you've got to know what is the protocol for the management. Because, if you are in a tertiary center, there has to be a definite protocol. Yes, for certain patients, based on your clinical sense and logic, you can actually just shift a bit, but you have got to know what is the protocol so that, you are not lost. Otherwise, if you are too haphazard, in the same institution, different doctors would be treating in different ways, and naturally the outcome also would be different. So always let's try to stick to the evidence-based guidelines as far as possible. So for the diagnosis of asthma, you have got to have two things. Okay, two things. One is you have got to have a history of variable respiratory symptoms. Somebody who is having a respiratory illness without any variation, okay, there is no reversibility, and suppose there is no variation for 6 years, is not a patient with asthma, because asthma means it is a reversible airway hyperresponsiveness. So you have got to have variability in the symptoms, plus you have got to have a evidence, like, suppose a patient says symptoms, you've got to have an objective demonstration. So there has to be a variable expiratory airflow limitation. So expiratory airflow limitation, because asthma is a obstructive lung disease, the problem is with expiration. So respiratory symptoms, you can have wheeze, shortness of breath, chest tightness, and cough. So all these symptoms would be varying in intensity, okay, and they would usually be worse at the night time. One of the possible factors said that, why an asthma usually triggers at night time is because of a physiological dip in the body's cortisol production is said to be one of the factors. And they are having various triggers. As I said earlier, you can have various triggers for asthma, and even viral infections. When there is an infection, that again can serve as a trigger. Now coming to the evidence or objective part of demonstrating a variable airflow limitation. See, first of all, it is an obstructive airway disease. So which means what will happen to the FEV1 to FVC ratio? The ratio would be less. Okay, it will be below the lower limit of normal. Below lower limit of normal. So that is one the criteria that should be there, because at once during the diagnostic process, which means, it is not like any asthmatic patient, anytime you test, you will get a low FEV1 to FVC ratio. No, because see, suppose you are testing at a time when the patient is not having any symptom, his FEV1 might be normal. So they say that at a time when the FEV1 is low, if we check the FEV1 to FVC ratio, it will be low. Okay, I hope you understood the point. Second is, again, to demonstrate the variability, you have got to demonstrate something that is known as a bronchodilator reversibility. Bronchodilator reversibility. So what is this bronchodilator reversibility? That is, when suppose you are having a asthmatic episode, you are naturally likely to take an inhaled bronchodilator. So when a patient is having an asthma and you take an inhaled bronchodilator, since it is a reversible airway obstruction, the FEV1 ratio, FEV1 should improve, correct, no? So the entity bronchodilator responsiveness or bronchodilator reversibility means your FVV1 is increasing by 12% or 200 ml when you put it quantitatively. So an FVV1 increase by 200 ml and 12% of the baseline value should be demonstrated after inhaling a bronchodilator. Usually we take it as 15 minutes after inhaling bronchodilator. So if you are able to demonstrate a bronchodilator reversibility, it is likely that this is a case of asthma. Because in case of a COPD, you are less likely to get a significant bronchodilator reversibility. Okay, because asthma is mainly a reversible illness and COPD is not that reversible as in case of your asthma. So you have got to demonstrate bronchodilator reversibility to establish a diagnosis of asthma. Also, in addition to the FVV1, you can also rely on the peak expiratory flow rate. Okay, PEFR, that is your peak expiratory flow rate. That is, if the daily diurnal fluctuation of your PEFR is more than 10%, that again satisfies the criteria. In children, the cutoff is taken to be more than 13%. Okay, so a PEFR, average daily diurnal variation of PEFR more than 10% in adults, and in case of children 13%. Very clear. And also the same criteria that we set for a bronchodilator responsiveness, that is the FEV1 more than 12% and 200 ml from the baseline after 4 weeks of anti-inflammatory treatment. Because suppose you have started the patient maybe on some oral corticosteroids. Okay, so patient came with you with some respiratory illness. You have not given the patient an inhaled steroids, but suppose you have put the patient on some anti-inflammatory therapy, like suppose I have started the patient on oral steroids. So in around 4 weeks, after 4 weeks, if he has got an improvement in the same parameters of FEV1, 12% and 200 ml, then also it is again satisfying the criteria of a reversibility of the expiratory airflow. Okay. Alright, so by now I am sure that you have understood what is an asthma, how do you diagnose. Remember, you have got to have symptoms which are reversible and you have got to have objective demonstration of a reversible expiratory airflow limitation. That is how you will diagnose bronchial asthma. Okay, very clear. Now just to show you pictorially, that is we are showing you a flow volume loop. To tell you what is this reversibility. You see here, this is the inspiratory part of the loop. Okay, this is the inspiratory part of the loop. And above is the dotted lines will actually show you the actual expiratory part of the loop. But in case of bronchial asthma, what happens is that since there is an expiratory limitation, the PEF, you can see the expiratory part, you can see there is a concavity. Okay, there is a concavity in the expiratory part of the flow volume loop. Can you see the concavity? And you can very well see the dotted line which actually shows the original expiratory loop. Okay, so there has been a significant concavity in the expiratory part of the flow volume loop. Now this concavity that has developed during the time of an asthmatic episode is reversible when you give a bronchodilator. That is, when you give a bronchodilator, what will happen is that you will have a shifting of this concavity to the original part or maybe at least near normal. Okay, so there is a change. You will have an increase in the FVV1, okay, by more than 12%, okay, or 200 ml. So that is what you have got to know in the flow volume loop, because sometimes they might, to integrate a physiology and medicine, they might, to test your knowledge, they might give the picture of a flow volume loop as well. Very simple. Okay, so this is what they will give a picture before the bronchodilator therapy and after the bronchodilator therapy. And yes, if you have got a significant reversibility, sometimes they might even give the FVV1 values. So you have got to think, is there an increase in more than 12% or not? And then accordingly you can make a diagnosis. Very clear, pakka. All right. So now let's discuss regarding the management of bronchial asthma. Okay, important topic. Management of bronchial asthma. So bronchial asthma is such a common condition, and it is very essential for a physician to know how best you can manage a case of bronchial asthma. And with respect to bronchial asthma, the management guidelines that you have got to learn is the GINA guidelines for the management of bronchial asthma. Okay, what is it? It is the GINA guidelines. Okay, GINA guidelines for bronchial asthma management. And what is this GINA? It is actually the short form for Global Initiative for Asthma. Okay, the G, I, N and A, the short form is GINA guidelines. So as an association, the GINA actually was formed way back in 1993. Okay, and ever since then they have made recommendations in the management of bronchial asthma. And with time, there has been revisions of the guidelines as well, the GINA guidelines. So the latest GINA guidelines is actually the 2021 update. Okay, 2021 update of the GINA guidelines, that is the latest. And as always in medicine, you have got to stay updated with the latest guidelines. So our discussion on the bronchial asthma management will be centered around the 2021 GINA guidelines of bronchial asthma. Okay, all right. See, when it comes to the management of bronchial asthma, the GINA guidelines actually say that there are certain goals of asthma treatment. Okay, there are certain goals of asthma treatment. Because when you are trying to treat a patient with bronchial asthma, what are you trying to achieve? Well, one thing is quite clear. You have got to bring the symptoms under control. Yes. And also you have got to attain risk reduction. Okay. These are the two broad goals of bronchial asthma management. So just going more into it, when you treat a patient with bronchial asthma, you definitely want to have the patient with very minimal symptoms. So a few asthma symptoms and no sleep disturbances, because many a times you might have an asthma exacerbation disturbing the sleep and you do not want to affect the sleep of the individual. So there should not be any sleep disturbances. The bronchial asthma should not cause any exercise limitation in the patient. So there should not be any exercise limitation. So these are the main symptom control measures. And then when it comes to risk reduction, you have got to maintain normal lung function, because we know bronchial asthma is an obstructive lung disease. Your idea of bronchial asthma is also that it is a reversible airway hyperresponsiveness that occurs in bronchial asthma. So you have got to bring the symptom center control as well as maintain normal lung functions. You have got to prevent flare-ups, okay, because asthma is one disease that can have exacerbations. So you have got to prevent exacerbations also happening in the individual. You have got to prevent asthma-related deaths. Now this is again important because asthma is a very much easily treatable condition, except for a few varieties of asthma which are slightly difficult to treat. But otherwise, it is definitely amenable to treatment, and there should not be a scenario where you have been careless in the management of asthma, because only then it can lead on to the death of the patient. Okay, so and also avoid medication side effects, because in due course of the discussion we will understand that there are different medications available for bronchial asthma treatment. And some of them have their own share of adverse effects, minor adverse effects. So you have got to minimize the adverse effects also. So you have got to choose the right drug in the right dose for the individual, and for which you have got to be very thorough with the guidelines. All right. Okay. So these are the goals of asthma treatment. All right. Okay. Now next we'll have a short discussion on the medications, the medication options available for bronchial asthma. Okay, what are the options that we have? And once we have a quick run through the options that we have, we'll then move on to the proper guidelines that how to utilize these options, treatment options. Now the asthma medications that we have in our armamentarium, you can broadly divide it into three groups. Okay, three groups. So number one is the controller medication. Okay, number one is the controller medication, or you can even call it the maintenance medication. Okay, even call it the maintenance medication. Then you have the add-on control medications, okay, which are add-ons. Then you have the reliever medications. Okay, so reliever medications, you can also call them rescue medications. Okay, basically used to treat a particular asthma attack. Okay, whereas when it comes to controller, it is the drug that you are giving to prevent further flare-ups, okay, and to maintain the patient. So that is the maintenance therapy. Reliever is actually the rescue therapy. And next we are going to see what all options are there in the controller medications, add-on controller medications, and the rescue medications or the reliever medications. Now first coming to the controller medications in bronchial asthma. So controller medications in bronchial asthma, number one, you have the ICS or the inhaled corticosteroids. Okay, inhaled corticosteroids can be used as controller. Then you can go for combinations. Okay, because in various medical conditions you go for combination of drugs. So similarly here we can go for combination of a inhaled corticosteroid and a long-acting beta agonist. So it is the ICS-LABA, okay, ICS-LABA combination of an inhaled corticosteroids and a long-acting beta agonist. So you can call it the LABA, ICS-LABA combination. Now third is leukotriene modifiers, and fourth is the chromons. So these are the agents available. Okay, so these are the agents available. Now we'll just quickly see in a brief about these individual agents. First of all, moving on to the inhaled corticosteroids. Now inhaled corticosteroids, the point you have got to know is, so ICS you are having different formulations. Okay, you have different agents available, as well as the individual agents are available in low dose, medium dose and high dose. So why is it essential to know this? Because when I teach you the guidelines per se, okay, in a short while, I will be using terms like low dose ICS, medium dose ICS, high dose ICS. So that should actually give you a clarity on what I am meaning. Okay. So the inhaled corticosteroids for adults and adolescents, it is divided into low, medium and high. Okay. Because naturally, we are discussing the adult and adolescent treatment here. We are not discussing the childhood asthma management, which is actually separately given in the JINA guidelines. Now, coming to various agents, you see, you have the beclomethasone dipropionate, you have budesonide, fluticasone, triamcinolone, different options are there. And you have different strengths, the low dose, medium dose and high dose. So if you take into account budesonide, okay, again commonly used one, you see low dose is 200 to 400 microgram, medium dose is 400 to 800 and high dose is more than 800. Similarly, if you take beclomethasone, 100 to 200, 200 to 400 and more than 400. So you have different formulations available, okay. And remember, for individual agents, the strength also, the low dose, medium dose, high dose also differs. But what is the point that we learnt now? The ICS, inhaled corticosteroids, there are different options available, and within each options you have the low dose, medium dose and high dose. Okay, all right. Now, next I told you can have combinations. Okay, you can have combinations of inhaled corticosteroids with the long-acting beta agonist. So here also you have different such formulations available. You have formulations of beclomethasone formoterol combination, budesonide formoterol, fluticasone propionate formoterol combination, fluticasone salmeterol, and fluticasone vilanterol. Different combinations are available. Now, out of all these combinations, okay, which I have listed before you, the maximum evidence, okay, for a treatment benefit, I'm talking of maximum evidence, is actually for the budesonide formoterol combination. Okay, yes, the other options are also effective, but the maximum evidence for effectiveness is for budesonide formoterol. Okay, budesonide formoterol. That is also clear. Now, after controller medications of the ICS LABA, let's move on to the leukotriene modifiers. So, the different leukotriene modifiers that are available, I'm sure the two common ones that you know of are the montelukast and zafirlukast. In addition to that, the pranlukast as well as silutan. Okay, and this leukotriene modifier group of drugs, in the year 2020, they got a FDA black box warning, okay, for a possible increased risk of suicidal tendencies. Okay, there is a black box warning for a possible risk of increased suicidal tendencies with leukotriene modifiers. Okay, and then coming to the chromones, again the famous sodium chromoglycate as well as the nidochromyl sodium. These are the options available. So we have seen about the controller medications or the maintenance medications. Now, in addition to the group of controller medications, you have the add-on control medications. Okay, so they are actually given as add-ons to the regular controller medications usually. And what are them? They are the one is long-acting anticholinergic. Okay, you can call them LAMA, long-acting muscarinic agents. So LAMA is there. Then you can have anti-IgE. Okay, there are monoclonal antibodies. So against IgE, against interleukin 5, either per se against interleukin 5 or against the interleukin 5 receptor, the anti-interleukin 4 receptor as well as the systemic corticosteroids, that is the oral corticosteroids. So this is actually the add-on controller medications. Okay, add-on controller medications. Now coming to individual agents, one is the long-acting anticholinergic. So we'll learn later, when to use these agents, but as of now we are just familiarizing with the agents. I know that most of you will be knowing about this. You have learned it detail in your pharmacology lessons. So you have tiotropium, which is long-acting. Then anti-IgE. Okay, anti-IgE as an add-on therapy is usually preferred in patients with severe allergic asthma who is uncontrolled on high-dose ICS LABA. So remember, I told you about terminologies like low dose, medium dose, high dose. So this is a scenario in which you will go for an anti-IgE. Again, when I say you will go for an anti-IgE, there is definitely a limitation with cost factors. Okay, using all these monoclonal antibodies, they're very costly. So anti-IgE, what is the agent that you have? Possible question. This is omalizumab. Okay, so the anti-IgE monoclonal antibody in bronchial asthma is omalizumab, and which is the scenario in which it is actually used is also important. Okay, severe allergic asthma, which is uncontrolled on the high dose ICS LABA combination. Okay, very clear. Now moving on to the other options in the add-on controller group, the other monoclonal antibodies. So other than the anti-IgE, we have antibodies against interleukin 5 as well as interleukin 5 receptor. So one very interesting fact that you should know about interleukin 5 is this interleukin 5 is a very, very potent eosinophil activating cytokine. Okay, this is a potent eosinophil activating cytokine. Okay, so in case of bronchial asthma, you have monoclonal antibodies that target either the cytokine or the receptor. So you have agents like mepolizumab and reslisumab, which are anti-IL-5, and benralizumab, which is an anti-IL-5 receptor. Okay, so you have got to know both these classes of agents. And when are these agents useful? Here again, they are useful in severe eosinophilic asthma. Why eosinophilic asthma? I already told you. IL-5 is a potent eosinophilic activating cytokine. So severe eosinophilic asthma uncontrolled on high dose ICS-LABA, that is when you use these agents. Okay, all right. Now coming to anti-IL-4 receptor. So the agent that is used, okay, the monoclonal antibody targeting anti-IL or targeting interleukin 4 receptor is dupilumab. Okay, so dupilumab is targeting IL-4 receptor, and this agent also is used in severe eosinophilic asthma uncontrolled on high dose ICS-LABA, or in individuals who require maintenance oral corticosteroids. Because when we discuss regarding the asthma management, we will understand, okay, that certain individuals with say severe asthma might require maintenance oral corticosteroids. And you know that it is not always good to have long-term oral corticosteroids for a patient because it has its own adverse effects. So the point is, in such individuals, you can again think of this option. Then as add-on controller medications, I told you, you can go for systemic steroids, prednisolone, hydrocortisone or methylprednisolone. So you can give the patient, say oral corticosteroids for bronchial asthma, but that is only given in patients who have a severe asthma. These are add-on controller medications. Now the last group of medications are the reliever medications or the rescue medications. Now what are the options available? Here you have SABA, that is short-acting beta-2 agonist. Okay, short-acting beta-2 agonists, which are bronchodilators. You call it SABA. Then you can go for combination drugs like low-dose ICS formoterol combination. Okay, is again a preferred reliever. And then short-acting anticholinergics also can be given for the reliever therapy. Okay, so these are the reliever medications available. We have learned in detail regarding the treatment options available for bronchial asthma. Now the options we have got, okay, we have a handful of medical options for bronchial asthma. Now you have got to treat judiciously with these agents, which is why we have guidelines to guide us, okay, how to select these agents. Now see, in case of Harrison, that is 20th edition, if you see, this is the management that is mentioned. You can see this is the stepwise management. But let me tell you one thing, this management mentioned in the 20th edition of Harrison is outdated. Okay, so you need not learn this. Okay, because this is the old guideline. Because now certain terms like, the intermittent, the mild persistent, these terms, which are slightly ambiguous terms are now removed from the latest JINA guidelines. And also this is not the exact treatment guideline that we follow now. So don't look and learn this from Harrison. It is outdated. You cannot say that, see, Harrison is a standard textbook, so shouldn't we learn what is written in Harrison? Yes, Harrison is definitely a standard textbook, but you should also understand that medicine is always an ever evolving science. So suppose, if you are in 2021, suppose a book was published in 2018, you cannot say that that is the state of art in management. Because see, lot has happened, okay, in this past few years. So new guidelines have come. So you have got to stay updated. In your exam also, remember that suppose somebody is framing questions for medicine, they are all treating clinicians, so they would know what these latest recommendations, latest guidelines are. It is not that there is some old guideline mentioned in Harrison, so I should put questions from that. This is totally outdated, so don't learn this. Okay, all right. Now, I told you GINA guidelines, the latest update that we have is the 2021 update. So whatever I am going to discuss now, because from now on the discussion will be centered around the stepwise management of bronchial asthma, because we have already seen the treatment options available. Now it's up to the stepwise management 2021. So you call it the GINA Global Strategy for Asthma Management and Prevention. Okay, once again, what is GINA? Global Initiative for Asthma. Okay, just like you would equate the term gold to COPD, GINA has to be equated with bronchial asthma. Very important. All right. Okay, so this is what we are going to learn. Okay, with respect to the GINA guidelines of bronchial asthma management. Now, does it look a bit complicated? Don't worry about it. I'm going to simplify it for you. To begin with, first point that you have got to know is that in case of bronchial asthma management, there are two approaches. Okay, there are two approaches. So once you have initially assessed the patient, you can go for either of the two approaches. Okay, but the term that is used in GINA 21 is not approaches, it is actually tracks. Okay, so there is a track 1 as well as a track 2. Okay, which means you can either go for a track 1 management or a track 2 management. Now, next point you have got to understand. Is it like when you have a patient with bronchial asthma, you can go for either of these tracks with equal preference? No. Always, the track 1 is the preferred approach. Okay, this is always the preferred approach, whereas track 2 is only an alternative approach. Okay, it is only an alternative approach, by which I mean it is only used in certain exceptional circumstances. Almost always we will go for track 1 for the management of bronchial asthma. So what did you understand so far? Once you have diagnosed a patient with bronchial asthma and you want to institute treatment, there are two tracks available, 1 and 2. The preferred one is 1 and the alternative approach is track 2. Now we are going to learn more about the individual tracks, track 1 and track 2, and how is the treatment strategy. Well, the track 1 we are going to move to that first because that is the preferred approach. Okay, so let's move to track 1 of bronchial asthma management. Okay, track 1. Okay, track 1. Now, whether it be track 1 or track 2, okay, management of a patient with bronchial asthma, there are two important cornerstones. One is a reliever treatment, that is whenever a patient is having an exacerbation of an asthma, you have got to relieve the symptoms. So there has got to be a reliever treatment in each track, as well as you have got to have a controller or a maintenance therapy also in each of the tracks. Okay, so that is common between both track 1 and track 2. Now in track 1, okay, now we are moving on to track 1. So the management of the patient is actually divided into various steps, because each and every patient of bronchial asthma, okay, suppose you have got 10 patients of bronchial asthma, you won't be giving the same medications to each of them. It is a personalized management. Okay, this is the same word that is being used in the GINA guidelines as well, personalized management, because each patient is different and one size shirt does not fit all. That is the same theory here. It has got to be individualized. The treatment has got to be individualized. I told you the treatment is actually different. So based on the severity of symptoms as well as the frequency of symptoms, you will divide the patients into various steps, okay, ranging from step 1 to step 5. Okay, so ranging from step 1 to step 5, you will categorize the patient based on the severity and frequency of symptoms. So you can see, the stepwise manner in which, the treatment algorithm moves. Okay, it's like a step, no? So with a lower frequency and severity in the lower step, step 1, 2, and a higher, severity in case of step 5. Okay, clear. Now, in case of the reliever therapy, okay, in case of the reliever or the rescue therapy, whether it be step 1, 2, 3, 4 or 5, whatever be the step, the preferred reliever therapy in track 1, remember I'm talking of track 1, is actually as needed. Okay, so reliever therapy in track 1 is going to be an as needed, like as and when the patient has a exacerbation, you give a low dose inhaled corticosteroid formoterol combination. Okay, so you go for a low dose ICS formoterol combination. Now this is very, very important because for many years, okay, for many years until the 2019 guidelines, at present we are discussing the 2021, but it was the 2019 guidelines which actually brought about a major shift in bronchial asthma management, wherein the previously, we always used to go for a short acting beta agonist, SABA, as the initial reliever therapy, but it was changed. A dramatic shift occurred in 2019 where it was advised that the preferred reliever for all the stages will be a low dose ICS formoterol combination. Now, why did this change occur? We will see subsequently in this discussion. Meanwhile, you can also have a thought on the possible reasons why. But whatever be the step, you see, ranging from step 1 to step 5, all these steps, okay, the preferred reliever therapy is as and when needed low dose ICS formoterol combination. What about the controller medications, okay, or the maintenance medications, okay, because you have got to prevent further exacerbations as well. Now, when it comes to controller medications, it depends on the various steps. Reliever, all steps, the same medications as and when needed. So when it comes to controller, see, step 1 and step 2 in track 1 are grouped together. Now, why is it grouped together in track 1? Because step 1 and step 2, the controller therapy is same, which is why it is categorized together. So step 1 to 2, that group in track 1 means the patient is having symptoms less than 4 to 5 days a week. So if the symptoms are less than 4 to 5 days a week, it is actually falling under the step 1 to 2 category. Why it is together group? Because, it has the same management. Okay, so that is called the step 1 to 2 category. Now, when it comes to step 3, step 4, step 3 and step 4 is more or less similar, except for a major difference. So what is the similarity between step 3 and step 4 is that in both these steps, the patient has almost daily symptoms. Okay, almost daily symptoms. You can see most of the days. And in step 4, daily symptoms, more or less means, patient is daily having symptoms. In addition to that, okay, in step 3 and step 4, another similar feature is at least once a week, okay, at least once a week, the patient actually wakes up with asthma, okay, because I told you already that asthma can or is often exacerbated, during the night times. So you can have asthma disturbing your sleep. So in the step 3 and step 4, another category is, patient waking up with asthma once a week or more. That is also similar. So till this much, step 3 and step 4 more or less similar. But the only differentiating point between step 3 and step 4 is that step 4 will have a low lung function. Okay, a low lung function. Okay. So that is going to be the differentiating point between step 3 and step 4. So in step 4, you will have a low lung function, which means, you will have a lower FEV1 value that is less than 80%. So lower FEV1 will be there in case of step 4. We know that in general, the asthma, there is the bronchodilate or the airway hyperresponsiveness is more often reversible. Okay, so once you give the bronchodilator, the symptoms actually reverse, except, in the later stages where you can have a definite affection of your lung functions, more affection. So the step 4, in addition to the symptoms of step 3, will also have a low lung function. And then you have step 5. And what is the step 5? Well, step 5 means step 4, in spite of giving the medications for step 4, it is still not controlled. Then you categorize the patient as step 5. Okay. So what are the medications used in each step? We'll come to that in a short while. But for the time being, understand that whatever is refractory to treatment in step 4 will be categorized as step 5. Okay. So categorization into the various steps is actually clear now for you. Okay. All right. Now coming to the individual treatment options in the individual steps. Okay. I'm going to talk about the controller therapy. Now step 1 or 2. Okay. So in the step 1 and 2, what is going to be the controller therapy? Now the interesting fact is that in step 1 and 2, if the patient is having a lesser degree of symptoms, that is step 1 and 2, the patient does not, take it from me, the patient does not require daily maintenance therapy. So there is no requirement of daily maintenance therapy. Okay. You need to give medications only as and when needed. What do you mean by that? See, what I mean is that that in case of the reliever therapy, you are giving as and when needed ICS formoterol. And the ICS formoterol that you give as and when needed will serve as a controller therapy as well for patients who are categorized as step 1 and 2. So step 1 and 2, the point I am telling you is that you can go for as and when needed, because there is no need for daily maintenance, as and when needed, low dose ICS formoterol combination. Okay, low dose ICS formoterol combination you can go for, that will serve as the maintenance therapy. You do not require daily maintenance. It is not that severe. Okay, that is also clear. Now, when it comes to step 3, okay, when it comes to step 3, major difference is that it is from step 3 that you require daily maintenance. Okay, it is from step 3 that you require daily maintenance. And for step 3, you are going to give the patient a low dose ICS formoterol combination daily. Remember, daily you have got to give the patient maintenance therapy in step 3. But remember, it is going to be a low dose ICS formoterol. Now when it comes to step 4, okay, remember, very similar to step 3, but difference is that there is low lung function. So in maintenance therapy also you will require a higher dose. So here also it is daily dose maintenance, but the difference is that you will, instead of low dose, you will go for medium dose ICS formoterol. Okay, medium dose ICS formoterol you will go for daily. Okay, so you see step 1 to 2 as and when needed. Step 3 low dose maintenance ICS formoterol. Step 4 medium dose maintenance ICS formoterol. Is it clear till now? Yes? Okay. Now let's move on to step 5. Okay, let's move on to step 5. Let me clear this. Okay, we are still in track 1. Okay, the picture you are seeing on screen is that of track 1. Now, if the patient was on step 4 and again was not controlled in spite of a medium dose combination of ICS formoterol, then you will categorize the patient as step 5. Okay. So next question is, how are you going to manage step 5? So when it comes to step 5, you will require a high dose ICS. Okay, a high dose ICS formoterol combination. High dose ICS formoterol combination. Now, in addition to that, okay, in addition to the high dose ICS formoterol, there are certain other agents that you can consider, which includes LAMA, okay, the muscarinic agent, so long acting, so like tiotropium. So you can go for LAMA, that is one option, and then you can go for the biologicals. Now, is it necessary that step 5 should have all these in combination? No, it's not like that. Initially, you start with ICS formoterol, high dose ICS formoterol. You can go for add-on LAMA. Remember, not separate. It's always add-on LAMA. So you can have at a particular time, a combination of ICS plus LAMA plus LABA, because the formoterol is a long-acting beta agonist. So you can go for a triple combination. Okay. Now, otherwise, if it is not getting controlled, then you can even go for the biologicals. But often, you will go for the LAMA as the next step, because it is in addition to the high dose ICS formoterol, because there is cost problems. Okay, these biologicals are very costly as of now. So because of the cost issues, you will go for the add-on LAMA. Okay. Now this is how you will manage patients with bronchial asthma in a stepwise category. Now suppose when the patient presents to you, he is in step 3. Okay. He is in step 3. Suppose he is in step 3. Okay. Just let us think of a scenario where at presentation, the patient is in step 3. Now, if the patient is in step 3 at presentation to you, you have got to give the patient as maintenance, low dose ICS formoterol combination. But remember, you have categorized this patient as step 3 as of now. It doesn't mean that for life he is going to be in step 3. He might come down to step 2 or step 1, or maybe again, as probably, if the disease is worsening, he can go to the step 4 and step 5 as well. So your management decision will be dependent on what step the patient is currently on. Because if the patient, initially you started this patient on daily low dose ICS formoterol, and in the next follow-up visit you assess the patient, you find that the patient is in step 4. Okay, so he's having a low lung function as well. In that case, you will go for a medium dose. You will go for a medium dose ICS formoterol combination. You will go for a medium dose ICS formoterol combination. So it keeps actually changing based on your assessment, which is why I told you it is a personalized approach. It is not like, okay, 2 months later you go for this drug and 1 month later you step down like this. It always depends on your assessment at follow-up. You review the symptoms, how frequently the patient is now having symptoms, how disabling is it waking him up from the sleep, and what about his lung function. So then, you take a decision accordingly. Okay, so I hope track 1 is very, very clear to you about the reliever therapy and how you will institute the maintenance therapy and how you will change between these steps. Okay, step 3 to down to step 1. So you can go down the step as well as you can go up the step, as per your treatment preferences after your patient assessment. So tell me guys, are you clear with track 1? Okay, now let's go to track 2. Okay, all right. So now we are going to go to track 2. Okay, we are going to go to track 2. So I already told you track 2 is not the preferred approach. It is an alternative approach. Okay, it is an alternative approach, and that is used only in certain exceptional circumstances. Now, is track 2 drastically different from track 1, or are there similarities? Well, there are similarities but with dissimilarities as well. Now, what is the major difference between track 1 and track 2? The major difference is actually with respect to the reliever therapy. Okay, the major difference is with respect to the reliever therapy. So in track 1, we saw that the reliever therapy at all stages was the low dose ICS formoterol, as and when needed it was given. Whereas in case of track 2, the preferred reliever therapy is as and when needed SABA. Okay, short acting beta agonist. Okay, so as and when needed SABA you give. Okay, so as needed you will go for a short acting beta agonist. Okay, as needed you will go for a short acting beta agonist. Okay, all right. So this again is a bit of an interesting area, because remember I told you from 2019 we came to the understanding that we should not go for a SABA only treatment for an acute episode. Yes, I stand by that even now. Why? I'll tell you. See, yes, the reliever is as and when needed SABA, but you see here also you have a stepwise categorization, and I'm going to teach you why I still stand by the term, like SABA only treatment is not preferred. So here also you can see beautifully the stepwise categorization of the patient. But here you can see, since the maintenance therapy is different for 1 and 2, it's separately categorized. Okay, step 1 and 2 are separately categorized. Now, what is step 1? Let's try to understand these steps just like in the order that we went for track 1 as well. Step 1 means the patient is having symptoms less than twice a month. Okay, the patient is having symptoms less than twice a month. That is step 1. Whereas when it comes to step 2, the patient is having symptoms more than twice a month. Naturally, this is a higher step, but it will be less than that of your step 3. Step 3 onwards, it is exactly same as that we discussed in the previous track 1. So, but this will be less than 4 to 5 days a week. So, that is going to be the category of step 2. All right. Okay. Now, step 3 and step 4, just like as we discussed in the track 1, almost daily symptoms, waking up from sleep because of asthma at least a week, once in a week or more. So, but additionally, low lung functions will be there in step 4, and whatever is not managed in step 4 is categorized as step 5. Very clear. All right. So, the categorization I suppose is actually clear, and now we'll go to the management. Now, you see, in step 1 and 2, in case of track 1, I told you, the reliever therapy was acting as the controller as well. Okay. But here in step 1, whenever you have a patient with the exacerbation of asthma, in case of your track 2, along with your SABA, you should definitely give a controller medication. That is, you have got to give the patient inhaled corticosteroids also whenever you are taking SABA, which means, let me simplify it for you. If you are having a patient with a bronchial asthma and he is having an exacerbation, if you are giving the patient SABA as a reliever, you are definitely supposed to give the patient ICS also. And that ICS will serve as the controller. Okay. So here, remember, you have got to give ICS also, which will serve as a controller, which is why I stand by the term I used, that in case of track 2 or whether it be track 1, whatever it is, you should never ever give SABA alone treatment. Because in track 2, SABA is the reliever, but will you give SABA alone? No, you are giving ICS. Only point is that ICS there will serve as the controller therapy. Okay, clear. Now moving on to step 2. Okay, step 2. Now in case of step 2, okay, in case of step 2, in case of track 2, how are you going to manage? Here you will give the patient low dose maintenance ICS. Okay, low dose maintenance ICS, and that has to be given daily. So in case of step 2, what are you going to give? Low dose maintenance ICS. Okay, in step 2. Whereas when it comes to step 3, you see here they are giving a low dose maintenance ICS LABA combination. Okay, you are going for a ICS LABA combination. So LABA means it can be any of the long-acting beta agonist. Okay, formoterol or whatever, any of the long-acting beta agonist. Step 3. Now step 4. Okay, step 4 is actually, I told you the definition, but here you can go for either medium or high dose. Medium or high dose ICS LABA combination. Now this is slightly different from that of track 1, because in track 1 step 4 you were giving a medium dose ICS formoterol combination. But when it comes to step 4 in track 2, you can go for a high dose also here. Okay, a high dose ICS LABA combination as well. Okay, so you are clear with the maintenance therapies in the step 1, 2, 3 and 4. And what about step 5? Well, step 5 again, just like the track 1, here also you can go for the high dose. You can go for the high dose ICS LABA combination, but remember, you were giving this in case of step 4 as well. So you can go for an add-on LAMA, or you can go for a biologicals. Once again, let me remind you, it's not necessarily to have all these together. You will have a high dose ICS LABA, plus you might go for a LAMA and biologicals. So biologicals, depending on the cost issues and where you are working, whether it is a tertiary care hospital with enough and more facilities and the patient is affording. Okay, all right. So this is also clear. Now another point I want to tell you is again common between track 1 and track 2. When it comes to the step 5, you can also go for oral steroids. Okay, this is same for track 1 also. Okay, you can go for the short course oral corticosteroids, but they are never advised on a long term. Okay, but the point you want to understand is systemic steroids may be given in the step 5 of both track 1 as well as track 2. Okay, so that is again very important. Okay, rarely you might give it in step 4 as well, but this is in general regarding track 1 and track 2. Now I know that there are certain questions still lingering on your mind. You said track 1 is preferred and track 2 is alternative. So why should you go for track 2 if at all you say that track 1 is the preferred? So what are these exceptions? We'll come to that in a short while. But as of now, you tell me guys, are you clear with the option strategies of track 1 as well as track 2 for both the reliever as well as maintenance? Yes? Is it a thumbs up? Okay. Now let's move ahead. Okay, let's move ahead and just try to compare the track 1 and track 2. So this slide, that I am showing you is taken exactly from the JINA guideline slide set. Okay, this is their own slide set, to give you an impression of these guidelines, and it stays in your mind also and how important these guidelines are. So as we have discussed, the JINA treatment is now showing 2 tracks. Okay, and you have a track 1 with a low dose ICS formoterol as the reliever, that is the preferred approach. Track 2 with SABA as the reliever is the alternative approach. Okay, all right. Now, when do you prefer, we are going to answer the question, when do you prefer the track 2? Now, track 2 is preferred in, a couple of scenarios. One where, for some reason, the track 1 is not possible. Okay. So it is not possible for a track 1 to be followed, maybe because of some medication availability, you're not having a ICS formoterol availability, whatever reason, it is track 1 is not possible. Okay, and the patient, is personally not preferring, he feels, he doesn't want that track, he himself feels, there is not much relief with that. So you have got to take into account the personal patient preferences as well. Okay. And also if the patient was already on maybe a track 2, okay, and he feels relatively happy with track 2, then you do not want to change him from track 2 to track 1. Okay, so these are the scenarios in which you will go for a track 2 therapy, but otherwise almost always it is track 1 that is preferred. And within a track also you can either step up or step down. Okay, so the treatment may be stepped up or stepped down within a track. Okay, so that also we have seen using the same reliever, but again you are changing the maintenance therapy. We have seen that in detail. Okay, all right. Now I told you it was in 2019 that a major change occurred, that is a landmark change occurred with respect to asthma management. And it was from 2019 that the JINA no longer recommended SABA alone treatment. Let me be clear again, it doesn't mean that you never give SABA. Remember, it is SABA only treatment is not recommended. Okay, which means even in track 2, when you are giving SABA, you are giving an ICS also along with that. Okay, so no SABA only treatment. Okay, now why this decision actually came? Because it was seen, in various randomized control trials, we understood that when you go for a SABA only treatment, which was the practice that was preferred for so long, there is an increased risk of exacerbations. Okay, so there was an increased risk of further exacerbations when you gave SABA only without an ICS. So because it increased the exacerbations, we took a decision, okay, so no longer SABA only. If at all you are going for track 2, give an ICS also if it is step 1. Okay, so JINA now recommends that all adults and adolescents with asthma should receive an ICS containing controller treatment as well. Okay, should get an ICS controller treatment as well to reduce the risk of exacerbations. All right. Now, again, sticking on to the same, the risk of SABA only treatment, just to see, the mechanisms also, because as of now, I understood, okay, you've got a picture like SABA only, there is some problem. So, but why does this occur is because, of factors. Okay. So, regular use of SABA, even for 1 to 2 weeks, is associated with adverse effects. And the reasons are beta receptor downregulation, decreased bronchoprotection, rebound hyperresponsiveness, decreased bronchodilator responsiveness, and increased allergic response and increased eosinophilic airway inflammation. So there are multiple factors contributing against risk of asthma exacerbations when you go for a SABA only treatment. You see, even for 1 to 2 weeks you give SABA only, that can cause all these problems. Okay, and various trials showed that higher use of SABA resulted in adverse outcomes. And also it was shown that inhaled corticosteroids have their own beneficial effects. So when you give ICS, okay, along with this SABA, that reduce the risk of asthma deaths, hospitalizations, and exacerbations requiring OCS, oral corticosteroids. Because I told you oral corticosteroids are given only for the step 5 cases. Okay, so these are the problems. So by now you have got an idea, okay, why this landmark change and why it is called a landmark change. Because see, even before that, the time where I was doing my medicine residency also, we used to always give the short-acting beta agonist as a reliever therapy whenever somebody had an asthma exacerbations. But see, the more we understand about a disease, our thought process changes. We learn better, and the guidelines change, and now we have got to stick to the recent guidelines. Okay, important. Okay, so I hope you are able to make sense out of the 2 guidelines, that is, or 2 tracks, track 1 as well as track 2. So the preferred track is the above one, and the alternative approach is the below one. When to go for the alternative approach is also very clear now. So again, just to reinforce whatever we have learned, this slide is also from Gina, exactly what we have learned. So Gina track 1 preferred, the reliever is low dose ICS formoterol. So why, the question is, why is this preferred in adults and adolescents? Because it reduces the risk of severe exacerbations compared with SABA as the reliever. So a head-on comparison between a low-dose ICS formoterol versus SABA shows that when you use ICS formoterol as the reliever therapy, further exacerbations are decreased. All right, and we have seen how it is used, and we have also seen that when it comes from step 3 onwards, it is, I am talking of track 1, it is step 3 to 5 we are having a maintenance and reliever therapy. Because in track 1, if you remember, step 1 and 2, the reliever therapy was also acting as the control therapy. Okay, so step 3 to 5, the patients also take the ICS formoterol as their controller therapy. The dosage actually varies, low dose, medium dose and high dose. So step 3 to 5, okay, is actually called, in track 1 it is called MART. And what is this MART? It is maintenance and reliever therapy, which means you are giving a maintenance therapy as well as a reliever therapy from step 3 to 5, from step 3 onwards. So you may be asked a question, MART in track 1 is used from which stage? Step 3. Okay, all right. So when should it not be used? That is track 1. Okay, when the patient actually prefers a different ICS LABA, because you see, when we discussed the track 2, we were using the term ICS LABA rather than using a term formoterol. So suppose if the patient actually prefers, patient preferences as also to be given due importance. So the patient feels, I'm not getting much relief with formoterol, but there was another LABA with which I got relief, then also you will actually go for the track 2, because track 2 is where the other ICS LABAs are actually preferred. Okay, but the essence is basically the same. You are giving the patient a combination therapy of a inhaled corticosteroid and the long-acting beta agonist. Okay, all right. Now Gina track 2 is the alternative, where the reliever is actually SABA. So where the track 1 is not possible, or it is not preferred by a patient, okay, and who is having no exacerbations with track 2, is already on track 2 by some doctor, you do not want to change it, because in medicine, the basic principle is do no harm. So if somebody is very controlled on some medication, I think you better stick to that. Because when we manage patients with epilepsy also, there might be some scenarios where the patient might be referred to us for some reason, or he comes to us and he is on some medication, anti-epileptic, and sometimes he might be on a very subtherapeutic dose of an anti-epileptic, which might not be even physiological, but the patient might say that, doctor, ever since I have been taking this medication, for the past several years I am not having seizures. Once I actually stopped the medication, say 2 years back, then I developed a seizure, but then I am continuing the medication, I have not had a seizure. See, you might think that, see, this patient is not on an adequate therapeutic dose. But if you take the EEG also and you find, then also there is no activity, then I think it is always better to leave the patient like that. You continue with the treatment. Okay. Now the statement which I am saying is not backed by any guideline, but this is something, when I was also trained, my professors actually told me there will be certain exceptions where it might seem a bit, curious for you that how this patient is actually getting controlled with this subtherapeutic dose, but maybe his body habitus is like that. So in that case, it is better that you do not make much changes. You stick to that. Okay. Again, do no harm. All right. So we have seen already, how is it used? We have already seen. Okay. There is no need to tell you. But one point you have got to know is that it is from step 2 onwards. You are giving the patient both the maintenance and reliever. Because in step 1 in track 2, whenever you are giving this patient SABA, you give the patient ICS. Okay. All right. And so when it should not be used. Now this is actually very important. So what is the scenario in which you should definitely not use SABA? Now the scenario is such that, suppose you have a patient. He is like, whenever he develops an exacerbation, he takes SABA. But he never takes ICS along with it. How much ever you tell him, he just says, doctor, I am fine with SABA alone, just one medication would do. So in such patients, you do not want to give track 2 because we know backed up by data that if you give SABA only treatment, there is a higher chance of exacerbations. Okay. So because of that, if your patient, okay, if the patient is, you just check whether the patient is likely to be adherent to the ICS controller therapy as well. If he is not likely to be adherent to the ICS controller therapy, then what will happen is that it might be counterproductive. When you give a SABA alone treatment, higher chance of exacerbations, it is going to be counterproductive. Do not do that. I hope that is clear. All right. Now again, something again very, very interesting. Well, the 2021 guidelines of JINA also says that, see, in step 5, we know that in step 5, you might also give oral corticosteroids, whether it be track 1 or 2. You can think of giving add-on azithromycin as well. Surprised? Yes, it is true. That is in patients who are on step 5, okay, and remember, who are not being controlled by other measures, you can think of adding azithromycin 3 days a week. You might ask me, sir, are you serious to give azithromycin 3 days a week for lifelong? No, it's not lifelong. As long as the patient is in step 5, then you can basically remember what I told you. The medications that you are prescribing to a patient keeps on changing. It's always a personalized approach based on the review symptoms, how the patient is faring, how the patient reports the symptoms, how he's doing and how he feels, is he better? So you have got to take all these into consideration. So in patients with step 5, you can think of azithromycin 3 days a week as well, because it has shown in trials to reduce exacerbations in patients who require the higher dose medications. Naturally, the higher step patients would require higher dose medications, and it significantly reduces exacerbations in patients with eosinophilic or non-eosinophilic asthma. Okay, so that is actually important. So you can give the patient add-on azithromycin. Now suppose you have started the patient on all these medications. Now when the patient is coming for follow-up, how do you assess the patient is having control or not? Giving terminologies like well controlled, partially controlled, uncontrolled. Well, the slide that I am showing you now is actually from the 2019 guidelines. The 2021 guidelines does not use these terms, well controlled, partly controlled and uncontrolled. But I feel, these terms would help you in practice for you to have an assessment. Okay, is this a partly controlled one, a well controlled or uncontrolled? But the current 2021 guidelines of JINA has made it more simple. So they use terms only with respect to step and not these terms. But just let's try to understand these. So the level of asthma control, how do you determine that? It is based on certain questions. Okay, that is, you will ask the patient, in the past 4 weeks, that is in the last month, You have got to answer these following questions: whether there were day symptoms more than twice a week, whether a reliever was needed more than twice a week, any night waking. See, always, this is given importance. Even in the step also we saw that. Any night waking due to the asthma and any activity limitation due to the asthma. So these 4 questions are asked and you have got to give a yes or no answer. And if all these 4 questions the patient has answered no, then he will fall under the category of well controlled. If any 1 to 2 of these, out of these 4 questions, if 1 to 2 of these are having, then he is given partly controlled. Uncontrolled means, if 3 to 4 questions the patient says yes, I am having daytime symptoms more than twice a week. Yes, I am having reliever requirement more than twice a week. Nighttime wakening or activity limitation, 3 to 4 of this, it falls into the red part of the umbrella, that is uncontrolled. Now this is for you to understand, to use, when to use this well controlled, partly controlled and uncontrolled. Now we have seen in detail regarding the GINA guidelines, the track 1 and track 2. This is very, very important. Please go through it. Now let's discuss a few more other points which are included in the 2021 update, which was not there in the previous guideline as well. This is with respect to the COVID-19 and its impact on bronchial asthma. Now this is again important because you may get questions. Okay, this was last updated on 26th April 2021. Why the date is being mentioned is that because it is an ongoing pandemic. We may have more data, there may be changes, but this is the current latest data as of now. Okay, all right. So let's try to see the impact of COVID-19 and asthma. So basically, you needn't know too much in detail regarding the topic, but there are certain facts that you have got to know, which might be asked for your exams as well. So first point is, are patients with asthma at increased risk of COVID-19 or severe COVID-19? So there are 2 questions in that. You have a patient with a bronchial asthma. First question is whether he is having an increased risk of acquiring COVID-19. Okay. The second is, if at all he acquires COVID-19, is he having a risk of severe COVID-19? Well, the answer to both these questions is a big no. Okay. Because this is you might just actually confuse. You might think that they might have severe COVID-19, but that's not true. Because it was shown that the patients with asthma do not appear to be at increased risk of acquiring COVID-19, and also they are not at risk of severe COVID-19 as well. Okay, in patients with well controlled mild to moderate asthma. Severe asthma, we'll just come to that, but otherwise well controlled mild to moderate asthma, there is no such increased severity. Now what about patients with asthma? Are they at increased risk of COVID-19 related death? Okay, that is patients with COVID-19 mortality. Is there a chance that patients with bronchial asthma are at increased risk of COVID-19 deaths? Well, if it is generally well controlled, there are 2 aspects to this answer. If it is a well controlled asthma, they are not at increased risk of a COVID related death, because if they are well controlled. However, if they are not well controlled and they require oral corticosteroids, okay, suppose they require oral corticosteroids, or there has been a very recent hospitalization with a severe asthma like a step 5, those individuals, the answer is yes. Okay, so the well controlled answer is no, but if the patient is on a higher end step and requires oral corticosteroids and a recent hospitalization, then the answer is yes. Now, what are the implications on asthma management? We were discussing of these track 1 and track 2. Is there any difference in management in the scenario of COVID-19? Well, it does not make any such statements. The only thing it actually states is that you have got to have a good management, because one point we know is that those who are having a mild to moderate asthma, reasonably well controlled, are not having, a risk of COVID-19 related death. So try to have a good asthma management. Okay. And also this, if you are adherent to your medications, the controller medications, it will reduce the chance of exacerbations as well. Okay. All right. Now, an interesting question, has there been more asthma exacerbations during this pandemic? Well, the answer here again is no. Well, the exact reason is not known, but again, see, because, you were using all these masks, physical distancing, lesser exposure to allergens, there is no definite increase in, the asthma exacerbations during this period. So this particular slide, COVID-19 and asthma, there are a couple of other slides, but what we have learned from this is that as far as possible, try to maintain a good asthma control. Only in those who are requiring oral corticosteroids, recent exacerbations, they are the ones only at trouble. Okay, all right. So suppose, regarding COVID-19 and asthma, what about, the patient is on inhaled corticosteroids. Suppose the patient was on ICS for maintenance. What should you advise regarding medications? Should I advise the patient to, avoid these medications? Well, no. Okay, because you advise the patient to continue taking the prescribed asthma medications, particularly the inhaled corticosteroids, because they have shown some benefit as well. Because that as per the ICMR, AIMS ICMR guidelines, as of now, we are having steroids also in the management. The mild cases, we are using inhaled steroids as well. So you advise the patient to continue the management. And are inhaled corticosteroids protective? Well, in a particular study, it was shown that the inhaled corticosteroids, which are being used in patients with bronchial asthma, they have some protective role over, an individual who has no asthma and is not on any ICS. So there is some beneficial. Doesn't mean that, you have got to take ICS. Patients who are not having bronchial asthma should take ICS. No. But those who are having asthma, if you take ICS, there is a definite benefit. Okay. All right. So, and another very, very important point is that you should avoid nebulizers whenever that is possible. There may not be a possibility in certain scenarios where you would have to give the patient nebulizers, but otherwise, since there is a risk of, the aerosolization, okay, since there is a risk of aerosolization, certain scenarios, as and when possible, you avoid the nebulizers. So the risk of aerosolization, okay, and also patients should have a asthma action plan also, okay, how to actually deal, they should definitely be in contact with their treating physician, and you adjust the medication as and when needed. And see, about spirometry, we know that asthma patients might undergo spirometry, but since the pandemic is ongoing, so you avoid spirometry in patients with confirmed or suspected COVID-19, especially, in regions where there is a higher transmission of this COVID-19 ongoing. All right. And you've got to ensure that there is strict infection control procedures. Okay. If aerosol generating procedures are needed. Okay. So you've got to maintain good hygiene. Okay. Social distancing, mask, personal hygiene, everything is very, very important. Now, very importantly, many of you might have the questions regarding COVID-19 vaccines and asthma. Okay. So can patients with asthma on ICS, can they take vaccines? The vaccines have been studied, and as of now, we understand that in general, the vaccines are safe, and the allergic reactions to vaccines are actually rare. So you might ask me a question, suppose patient is having some allergy, okay, he's a known allergic patient. So can he take a COVID-19 vaccine? Well, there is nothing that prevents him from taking a COVID-19 vaccine. But, if there is a patient with allergy, it's always better to take the vaccine in a facility where you can manage an anaphylaxis. In the highly unlikely event of an anaphylaxis occurring, you should have the facility for management. Though it is very, very rare, you should have the facility for management. So that is the general practice that is, even undertaken in our country also. If the patient is having an allergic tendency, he is often advised to take the vaccine from a center where there is a facility for anaphylaxis management, okay, not a peripheral health center, where there is no facility available, okay, all right, okay. So in general, when you look into account the risk and benefits, patients with bronchial asthma definitely should take the vaccine, okay. There is nothing that actually prevents them from taking the vaccine, okay. Now, what about COVID-19 vaccines and biologicals? Because we have biological therapies available, though the use is actually limited as of now. However, if some patient is taking biologicals, one important point to be taken of note is that you should not give COVID-19 vaccine, and the biological therapy should not be given on the same day. Okay, it is not that the vaccines are contraindicated on individuals, but it should not be taken on the same day because it can interfere with the immune response to the vaccine. So do not take this because these biologicals will suppress your immunity, so the immune response will be affected. So what exactly should be the gap between a vaccine and a biologic? That is not mentioned in the guideline. The guideline as of now only tells us that do not take it together, okay. All right. So another point is regarding influenza vaccination. So patients with asthma, you have got to tell them to take the annual influenza vaccination as well. And then there might be a question, in case they are going for the influenza vaccine, can I take it along with the COVID-19 vaccine? Well, the guideline as of now, that is the CDC recommends, okay, there should be a 14 days gap between the COVID-19 vaccine as well as the influenza vaccination. Very clear? Okay. And as the pandemic evolves, as we get more data, there might be changes in these guidelines. But as of now, we have discussed in detail regarding the guidelines. So it is the GINA guidelines. Okay. As of now, what I have discussed with you is the GINA 2021 update. You've got to know this in detail. Please remember the Harrison 20th edition, the details given are actually outdated regarding the asthma management. So you have got to follow this, and I hope it is very clear how you will manage asthma systematically with these guidelines in mind. All right. Okay. So now we will discuss some very important terminologies with respect to bronchial asthma. So some of these terminologies have been mentioned in the GINA guidelines as well. So you have got to know these terminologies. So I'll introduce 6 terminologies to you, a couple of which I have already discussed before in this same module. But just to put it together, one is your uncontrolled asthma. Uncontrolled asthma. Second term is a difficult to treat asthma. Difficult to treat asthma. The third one is severe asthma. Severe asthma. The fourth one is brittle asthma. Brittle asthma. Then you have exercise induced asthma. Exercise induced asthma. And the final one is aspirin sensitive asthma. Okay. All right. 6 terminology. Now I'll just try to explain what these mean individually. First of all, I'm going to group these 3. Okay. Uncontrolled, difficult to treat, and severe asthma. All these terms appear very similar. Okay. But with respect to the definition, they are quite different. Let's see how they are different. First of all, uncontrolled asthma. Uncontrolled asthma. Now, when you say uncontrolled asthma, it means an individual is having frequent flare-ups of asthma. It is frequent flare-ups or exacerbations. That is when you say an individual is having uncontrolled asthma. Remember, this individual is not on any preventive or a controller therapy. It is just that he has been having asthma and he is developing frequent flare-ups, and you say this is uncontrolled asthma. So if you start a preventive therapy with, say, a low-dose inhaled corticosteroid, so in such a scenario, or low-dose inhaled corticosteroid LABA combination therapy, in such a scenario he might be very well controlled. Okay, so but for the time being he is a uncontrolled asthma. That is the first terminology. Now next one after uncontrolled asthma is a difficult to treat asthma. Difficult to treat asthma. Now in this entity, again the individual is having frequent flare-ups or exacerbations, but this occurs in spite of preventive therapy. In spite of preventive therapy, okay, in fact, you have already given this patient a high-dose inhaled corticosteroid LABA combination, but in spite of that, he is having episodes. Now, for this, there may be certain contributory factors. See, either the diagnosis may be wrong, okay, it might be a wrong diagnosis, because actually his problem might not be a bronchial asthma, or you have prescribed the preventive therapy, but the patient's adherence to the medications is very poor. That can be a reason. It can also be that he has a very poor technique of using his metered dose inhaler, because this is a problem that we commonly see in clinical practice. When somebody is advised on MDI, the patient might actually come back to us in follow-up telling that, doctor, you told me about this MDIs and that it will give me benefit, and I have been using it for some time, but I am not getting any proper or maybe a expected benefit. So the actual problem might have been that this patient's technique of using the MDI is not correct. Okay, that is important. So can also be another factor that contributes is that he might also have certain comorbidities that can again contribute to his maybe a respiratory illness, maybe some other, maybe respiratory or maybe non-respiratory, maybe a cardiac comorbid illness, because of which also he is having breathlessness. Okay, so because of all these, he becomes difficult to treat asthma. Okay, that is in spite of preventive therapy, but the actual thing is that it is one or more of these contributory factors that are leading on to this patient being a difficult to treat asthma. Very clear. Next issue is that of a severe asthma. Okay, a severe asthma. So what is this severe asthma? Okay, severe asthma. Now severe asthma means this patient is again developing frequent flare-ups, and you have given a preventive therapy, and you have taken care of all these as well. The diagnosis is right, his adherence to the medication is right, his technique of using MDI is right, and you have catered to all his comorbidities as well. That is, severe asthma means he is getting all these frequent flare-ups in spite of best optimized treatment. Okay, in spite of the best optimized treatment, he is getting flare-ups. That is called a severe asthma. Now, whether it be a uncontrolled asthma or a difficult to treat asthma or a severe asthma, what is the importance of these three terms? See, these are terms which are likely to be loosely used by treating physicians. For example, if I have a patient with an asthma, okay, and I am treating the patient, so if it is a patient who is having a frequent episode, I might casually write this is an uncontrolled asthma. The same patient, if he is under your follow-up, you might say, okay, this is a difficult to treat asthma. Somebody else would say this is a severe asthma. So it does not convey a meaning unless it has got a proper definition. Okay, which is why Gina has specifically defined these entities of uncontrolled, difficult to treat and severe asthma. So that when I say that this patient is having a severe asthma, you understand, okay, what did I mean by severe asthma? Okay, or maybe I'll be using this term, difficult to treat asthma. Okay, so it's important to understand these terminologies. All right. Okay, now let's move on to the next term, that is going to be the brittle asthma. Brittle asthma, I'm going to show you a picture because that is the picture that has to stay with you to remember this entity, brittle asthma. So you have heard of the term brittle diabetes, haven't you? So what is this brittle asthma? Brittle asthma means it's again the asthma in this particular patient will be having frequent exacerbations, almost like this. You see the frequency of episodes, he's having so frequent episodes. Okay, this is the graph showing the peak expiratory flow and the days. You see here he's having a lot of variability in his lung function as well. Okay, so lot of variability in his peak expiratory flow rate. So much of variation is, though asthma is a reversible airway disease, this much of ups and downs is not expected, but that is what happens in a brittle asthma. Okay, where an individual's pulmonary function test is dramatically changing. Okay, and that is again contributing to recurrence of his episodes as well. Now brittle asthma is of two types. Okay, the commoner one is the type 1, which I have exemplified in this diagram, and then you have a type 2 as well. Type 1 is the one you just saw, and for treatment of type 1 you go for oral corticosteroids. Okay, what is the treatment? Oral corticosteroids. Type 2, see, type 2 is quite different. It will be like, the graph will be like the patient is relatively stable, then develops an episode, then again stable for long time, then develops episode. So then you might ask me, this is the same that happens in any asthmatic episode. What is so brittle about it? Yes. What is so brittle about it? It is about the episode. Because the episode of exacerbation in case of bronchial asthma is very much unexpected and dramatic, and also severe. Because normally when an asthmatic patient experiences a trigger, he develops a worsening. But then again, it is something that is expected. There is a trigger, there is a worsening. But here, you might have no obvious trigger, and it is very much dramatic and severe. Sometimes he might land up in a respiratory failure also. So that is what is so brittle about your type 2 brittle asthma. And the management of type 2 brittle asthma is going to be subcutaneous adrenaline, because this is one condition that carries with it an increased risk of mortality as well. Okay, so that is your type 2 respiratory failure. Clear? All right. Next term, you have learned uncontrolled, difficult to treat, severe, brittle, exercise-induced asthma. I did make a mention of exercise-induced asthma in the beginning of this module as well. So you are very familiar with this term now. So I already mentioned at that particular time that there are two theories for this exercise-induced asthma. I just want to show you the theory. See, ultimately what happens in exercise is that there is water loss by evaporation, and because of that, two theories that can happen. One is going to be a thermal theory, and other is related to, is called the osmotic theory. So thermal theory means when there is a water evaporation, there is a mucosal cooling. Subsequently, there occurs vasoconstriction, reactive hyperemia, and subsequently what happens is there is vascular leakage and exercise-induced bronchoconstriction. Okay, mucosal cooling, vasoconstriction, reactive hyperemia, vascular leakage, and exercise-induced bronchoconstriction. You abbreviate it as EIB. Okay, exercise-induced bronchoconstriction. Now, this water loss will also contribute to certain osmotic changes. That is, you will have electrolyte changes. You will have an increase in the osmolarity as well, which would cause some cell volume changes, and it would result in the release of certain mediators. There will be change in the smooth muscle contraction. There will be some bronchospasm as a result of these mediators, again resulting in a exercise-induced bronchoconstriction. These theories are not very important from the exam point of view. I just wanted to tell you how this develops. But for your exam, which is important, is what is going to be the treatment of an exercise-induced asthma. So remember, exercise-induced asthma treatment is going to be short-acting beta agonist. Short-acting beta agonist is going to be the treatment. All right. Okay. So that is also clear. The last term is aspirin-sensitive asthma, which again we have discussed in the early part of the module. The only point I want to add on is that the treatment of this is going to be inhaled corticosteroids. Okay. So you might get a question on the drug. In fact, there has been a previous question also asked on the treatment of aspirin-induced asthma. It is going to be inhaled corticosteroids. Okay. So I hope you are familiar with these terminologies. Okay. All right. So now we will move on to the last part of this module. So far we have understood about bronchial asthma in detail. Now we'll go to the emergency management, that is the management of acute exacerbation of bronchial asthma. Management of acute exacerbation. How will you manage an acute exacerbation of bronchial asthma? So how are you going to deal with this? See, acute exacerbation of bronchial asthma truly is going to be an emergency. And here again you have the GINA 2019 guidelines for the management of bronchial asthma exacerbation. So what does the guideline tell us? So first, when a patient is brought to the emergency with an acute asthma exacerbation, the first step is the initial assessment. Okay, as is with many of the neurological emergencies, you will go for airway, breathing, circulation. That is your first priority. Very clear. Okay, you have got to check the airway, breathing and circulation, and you have to check the vitals if everything is fine. So that is the first step. Second step is to see whether this patient, important, whether the patient is having any features of impending respiratory failure. Okay. Now this is very, very important. Now what do I mean by an impending respiratory failure, or what are the red flag signs which makes me think of a impending respiratory failure? See, just imagine, okay, a patient presenting with an acute exacerbation of an asthma. So what picture do you have in mind? You have a patient who presents to the emergency. He is breathless, he is tachypneic, he is having some chest tightness, maybe some cough, and he is very much restless, agitated. You examine his tachycardia, tachypnea, and on auscultation you will have lots of wheeze as well, correct? Because of the bronchoconstriction, wheeze also on auscultation. That is what you expect. But what happens is that if the patient goes to a respiratory failure, rather than an agitated patient, you will see a patient who is maybe confused, okay, or he is having some delirium, okay, he is having some delirium or disorientation. And along with that, when you auscultate, what you are going to see will be a silent chest. Now, what do I mean by this? Normally, when you have a respiratory problem, you are seeing wheeze or you are auscultating wheeze. But sometimes when it goes, or when it is going to the stage of an impending respiratory failure, the wheeze might not be there. There may be a silent chest. Now here I want to tell you a very, very important piece of information. If you have got some patient in your emergency presenting with an acute asthma exacerbation, so the time you saw the patient, he was very agitated, and then you auscultated the wheeze. But after a while, another 15-20 minutes later, you find that the patient looks very much drowsy and you auscultate and you find that there is no wheeze. Remember, this is not a sign of improvement. If there is no wheeze which is associated with a deterioration of his sensorium, mind you, he might be landing up in a respiratory failure. Okay, because asthma is very well known to produce a type 1 respiratory failure, correct? So asthma produces a type 1 respiratory failure. So a patient can go in for a respiratory failure and you must be very vigilant about that. So let me take your attention to the flowchart of the guidelines of the GINA guidelines of the acute exacerbation management. So first I told you initial assessment. Then you look whether there is any drowsiness, confusion or silent chest. So these are features which would tell you that the patient is going for a impending respiratory failure. Now if the patient is going for an impending respiratory failure, the management is something else. So we'll come to that. But suppose if the patient is not having any features of impending respiratory failure, then how will you manage? Okay, that is what we are going to learn. So if there are no features of impending respiratory failure, now you have got to triage the patient. Okay, so the further triage of the status will be into mild to moderate symptoms or severe symptoms. So when do you say that a patient is having mild to moderate symptoms and when do you say he is having severe symptoms? The guideline says that if the patient talks in phrases, okay, he is able to talk in phrases, he prefers to sitting to lying, okay, over lying position, he prefers sitting position, he is not very much agitated, he is having tachypnea, the accessory muscles are not being used, there is some sort of tachycardia and he is able to maintain the oxygen saturation in the 90 to 95% range. And if you have a portable peak expiratory flow meter, you find that it is more than 50% of the predicted one. Now in these scenarios where he is able to talk, okay, so he is talking in phrases, not in words, he is able to talk in phrases. So which means this is only a mild to moderate exacerbation of bronchial asthma. Okay. On the contrary, rather than phrases, if he talks in words, or rather than regarding the position, whether he prefers to sit in a tripod position, okay, he prefers to sit in a tripod position with hunched forwards. If he is very much agitated and very restless and is severely tachypneic with a rate more than 30 per minute, the accessory muscles of respiration are being used, tachycardia more than 120 and his oxygen saturation, mind you, goes less than 90% and the peak expiratory flow rate is less than 50% of predicted. These are alarming signs. These are alarming signs. This is actually a severe asthma. Okay. So remember, if there are no signs of impending respiratory failure, you have to further triage it to the mild to moderate category or the severe category. You have just seen what are the parameters based on which you will categorize. Now, if it is a mild to moderate category, you can give the patient a short-acting beta-2 agonist. And how is this given? This is given inhalation. You can go for inhaled short-acting beta-2 agonist. Okay. What about intravenous beta-2 agonist? See, the GINA guidelines say that there is no compelling indication to use your intravenous beta-2 agonist. Okay. So only in such a dire scenario that you might go for an intravenous, otherwise it does not provide an added advantage. Okay, so in routine scenarios you can go for a inhaled beta-2 agonist. You can go for ipratropium, the anticholinergic. Yes, you have got to give the patient a continuous supply of oxygen. So you have got to maintain the oxygen saturation at around 95%. You try to maintain at around 95%. Guideline says 93 to 95. And you start the patient on oral corticosteroids. So remember, oral corticosteroids. Now what this guideline tells us that if the patient is able to take the oral tablet oral corticosteroid is as good as taking an intravenous corticosteroid. Okay, so there is no compelling indication for you to go for a intravenous steroid provided the patient is actually able to swallow the tablet, because sometimes he might come up with a difficult respiration, so probably it is not right at that time to remove the oxygen and ask him to swallow a tablet. So otherwise you can go for oral steroids. Now this is what you will do in the mild to moderate category. Now when you come to the severe category, see, these four are the same: short-acting beta agonist, ipratropium, oxygen to maintain saturation at around 95%. Here you might have to go, naturally when a patient is having a severe exacerbation, you might not go for oral steroids, you will go for IV steroids. In addition to that, you can go for IV magnesium, which you can give 2 gram intravenously over 20 minutes. So IV magnesium 2 gram intravenously you can give over 20 minutes. And also you can consider high dose inhaled corticosteroids. So two additions compared to the other category is the magnesium and the high dose inhaled corticosteroids. Now remember that aminophylline, okay, you remember if you look at the previous treatment guidelines, you will find that there is role for aminophylline, but currently they have taken out this aminophylline because of the risks and the adverse effects associated. So you are not going to see any aminophylline here. So that is how you are going to manage the severe category. And is it all said and done once you start the treatment? No. You've got to monitor the patient very closely, monitoring the oxygen saturation. So you see the improvement, you can use the peak expiratory flow meter as well. So if there is an improvement, okay, if it is improving to 60 to 80% of the predicted value, so then it is actually a reassuring sign. But if it remains less than the 60% of predicted, probably it indicates he is still in the severe category and you have got to continue the treatment. So it is very important that you treat severe asthma and even mild to moderate asthma also very aggressively. So regarding the choice of IV steroids, here you can go for hydrocortisone. So hydrocortisone you can go for 100 milligram IV stat followed by IV Q 8th hourly. Sometimes you might require a more frequent dosage like every 6th hourly if the patient is having severe symptoms. So parenteral you can go for a hydrocortisone, but always remember the additions, like you can go for magnesium sulfate. I am not saying that all cases you should add magnesium sulfate, but the guideline says that if the patient is triaged into the severe group, if needed, definitely go for magnesium. And suppose in spite of your best treatment, whether it be the mild to moderate or severe group, remember that a patient who initially comes to you and you have grouped it as a mild to moderate, after around say 15 to 20 minutes of admission might go to the severe category because he might be worsening. Also, this patient might go for a respiratory failure as well. So it is very important to constantly monitor all the parameters, whether the patient is able to speak, how is he tachypneic, and also another parameter that will help to ascertain the severity of a bronchial asthma is pulsus paradoxus. So pulsus paradoxus is again said to be an indicator of severe asthma. Okay, indicator of severe asthma. Now this severe asthma is not the severe asthma that we learned in the terminologies. Okay, this is with respect to the acute exacerbation, okay, and the categorizing into severe. So pulsus paradoxus is an indicator of severity. But again, let's come to the other group. Suppose you have got a patient who was brought to in the mild to moderate or maybe a severe stage, then goes for a respiratory failure, or maybe the patient was brought to a respiratory failure. In such a scenario, do not waste any time. You have got to intubate and ventilate this patient. The rest of the treatment is same as that for the severe asthma exacerbation, but it is very important that you ventilate because the patient has got a silent chest, no wheezing, And what happens is that often when the patient goes to a respiratory failure, the pulsus paradoxus also might disappear. Okay, the pulsus paradoxus might be there in a severe asthma exacerbation, but when it goes to the respiratory failure stage, this might disappear. So remember, whenever a patient's pulsus paradoxus disappear, if the patient is becoming further drowsy, it's again indication that he is going for respiratory failure. Okay, so in such a scenario, you have got to assess and you have got to ventilate this patient. The same is here when the patient is brought in a stage where he is going for a respiratory failure. You ventilate. The rest of the treatment is the same, but it is very important that it is an emergency, and when it is an emergency, you have got to treat the patient very, very aggressively. Okay.